So our next talk and final talk is by Dr. Rakna Murthy, and she's speaking on dermal filler complications.
Yeah, thank you very much. I have to say thank you to Jeremiah and Richard for inviting me along all the way from the UK to give you this talk, which is going to be concentrating on complications, but I'll give you a little bit of summary as well and put things in context. I am offsetting my carbon footprint. I have an electric car and solar panels on my roof, and I've eaten 2 Beyond Burgers in the last 2 days, so I'm trying to help towards that. So these are my associations, and these are my disclosures. So this is a picture I drew over 30 years ago of my eye, and what struck me then, and still strikes me now, is that the eyelid is a very delicate, intricate structure, and it has an important role to protect the eye. And as ophthalmologists and oculoplastic surgeons, we have this key role in that we can protect the eye. We maintain the function and the integrity and the aesthetic of the periocular area. So this is a little video that shows nicely how the face ages and the periocular area ages. And it's not just the eyelid, but the whole face. And when we are addressing the aesthetic changes and the functional changes in the eyelid, we need to address the face as well. We'll go to the next slide. There we are. This shows nicely what we were hearing about sun damage and how this actual patient in the New England Journal of Medicine in 2012 is a 69-year-old truck driver. You can see how sun damage on one side of the face has made significant increased lines and iridosis on one side compared to the other. So we have to address aging changes and solar damage changes when we're considering the aesthetic impact on our face and periocular area. So you've heard some of these already. This is our niche market. There is an increasing rise in some of these surgical aesthetic treatments, particularly blepharoplasty surgery. But patients and doctors are beginning to think that less is actually more. We can achieve far more by doing far less, and this is really important to remember. So non-surgical treatments are on the rise. We have to be aware of these, and certainly fillers have increased exponentially in the last 5 years, and particularly the hyaluronic acid filler market. These are a useful addition to our armamentarium. These haven't been a new addition to our toolbox. So as early as the 1800s, a Viennese surgeon was injecting paraffin wax into ladies to try and improve their lines. And that's when dermal fillers started to come in, but obviously were associated with quite a lot of complications. Collagen enjoyed a monopoly in this country and around the world up till about 1996. These were associated with quite a lot of complications and allergies. But overnight, the hyaluronic acid market took the collagen market by storm, and that's because they were thought to be inert. That's a ubiquitous molecule that's present in all living tissues, and thought to be related to very little allergy and complication. So the market is increasing. There is a huge demand for these products. The projected revenue by 2020 next year is over $10 billion US, and there is an increasing number of these treatments being done. And it's not just for aesthetic treatments, so we have to be able to use these treatments in our toolbox to treat functional problems as well. This is a patient of mine with thyroid eye disease who I treated medically for 18 months. But her main problem, as you'll hear later on as well when Jonathan gives the talk about thyroid eye disease, is that there was a significant impact on her appearance, and this caused her significant psychological distress. It would have been great to be able to treat her lid retraction, which we couldn't do in the UK with the use of dermal fillers. We had to wait until her eye disease was inactive before we could surgically operate. But this is a lovely picture that shows how Ray Douglas treated his patient with upper eyelid retraction in thyroid eye disease, active thyroid eye disease, and allowed improvement in function and closure of the eye, as well as the cosmetic appearance. A patient of Bob Goldberg's, who had facial nerve palsy and significant lagophthalmus on forced closure after the injection of hyaluronic acid to the upper lid, was able to close the lid well. The patient didn't want to have surgery. Maurizio Di Maio, a Brazilian plastic surgeon, has demonstrated well with facial nerve palsy patients how treating the face can improve the closure and the function of the orbicularis muscle. So, busy slide. The top row is at rest, static, not smiling. Second row, smiling immediately after treatment. And the third row, this is the one I wanted to concentrate on, you can see how the face isn't as distressed and disorganized when he's trying to close his eyes. And it's a long-lasting result. This is a patient of mine who's an aesthetic patient, but these aesthetic patients also do have significant psychological distress. She was concerned about her acne scarring, photoaging, loss of volume, and she was treated with 3 ml of hyaluronic acid for the skin and volume replacement to the cheek and periocular area. So the results with these products are immediate and long-lasting. This is 18 months after 3 ml of HA filler. There's got to be some result, some impact on the increasing use of these fillers in larger volumes and in deeper areas. And so we are going to see more complications. This is a summary of what Famida was saying, which is really very useful. So we have to remember that we are physicians as well, taking a good history, selecting the right patient for these treatments, consenting them regarding the financial implication, and consenting regarding the complications. Choosing the right product. Hyaluronic acid is excellent because we can reverse it. We have an enzyme. But we have to choose the right product for the right area. So this is Verbella. You can see how it's smooth. And we'll speed this forward. This is Voluma, the one that you might use in the cheek. Thicker. So you have to choose the right product for the right area. And we have to be aware of how our procedure can impact on the results and complications. A strict aseptic technique, know the anatomy, perhaps use a cannula in some areas which are higher risk. So even in the best hands, complications can happen. I'm not going to be exhaustive in terms of describing all of these. But this is the one that's most important for us as a group, because we can help to manage these patients. Blindness is the most, well, apart from blindness, we can also have rare cases of CVA, death, but blindness is the group of patients that we would be able to help with managing. Luckily, the vast majority of complications are mild and self-limiting. Famida talked a little bit about how we can avoid bruising. I prefer to use the cannula in the periocular area, others prefer to use needle, and it's all technique and experience. These are very common to see these little nodules. What's new in terms of publications that we haven't necessarily heard about so much is that these fillers can last for over 7 years in the periocular area. So a patient may present to you with a little nodule in the periocular area, not give you a history of having a previous treatment. These fillers can migrate from far away, from the face, from the temple to the periocular area. And these are very easily treated with hyaluronidase and massage, if it is a HA filler. Malar edema exists in about 10% of people anyway. If you're injecting a product that is in the superficial area where the lymphatic drainage is not as good, then we are going to increase the malar edema. So knowing where to inject is very important to try and minimize this risk. And this can be treated with hyaluronidase, and these patients can have further filler. So this is something that is also becoming more apparent, that these products are not as inert as we think, and they can last a long time. We are seeing more delayed onset nodules. These are inflammatory nodules. They were thought to be more infection-related. The problem is these aesthetic patients don't usually want to have a biopsy, so we are not usually able to get microbiology, but where we can get microbiology, they're normally culture negative. And what's becoming more apparent is that this can happen with any filler brand, and there is usually some kind of immunological trigger. So you'll see these little painful, sometimes red, sometimes tender inflammatory nodules occurring more often in the winter months when there are more colds and coughs. But it could be any immune trigger, a long airline flight, dehydration, local trauma with Botox on top of previous filler. So HA has an inflammatory role to play, and actually it can be anti-inflammatory as well as pro-inflammatory. These are treatable, hyaluronidase and steroid. Very often this has to be a delayed tapering of steroid over 6 weeks at least. So these are the things that are more devastating. The acute embolic phenomenon due to filler in the blood vessels, or compressive filler, which can be presenting a little bit later and as a delayed reaction and response. And these are treated with hyaluronidase and massage. I'm not going to go through the list because this is the one that we want to concentrate on. And blindness is becoming more common as these treatments are increasing. There's actually over 190 cases of blindness in the last 100 years. There was one a month ago in the UK, another a few months ago in Australia. And you'll be hearing about these more and more as more people are doing these treatments. And we're the group that will be asked to manage these patients. Why does it occur? There's multiple anastomosis around the face from the external and internal carotid arteries that supply the central retinal artery. This is an older paper that Katie Bolesne and her group published in 2015, and at that time, fat was thought to be the most common cause of vascular occlusion, and most commonly due to injection in the glabellar area. Updated now this year, as HAs are becoming more popular, it's a nose that is the most common site of cause of visual loss, and most commonly, over 80% of these cases are due to HA. Fortunately, these are potentially reversible. I say potentially because I'm going to talk to you about a few of the cases. So it's really important to know the three-dimensional anatomy and place the filler in the right place and be aware of where you can introduce hyaluronidase to try and treat these complications. So this was the case from Chestnut that led to large groups of people being taught how to do retrobulbar injections of hyaluronidase, aesthetic doctors. Unfortunately, this case, there was no objective assessment of vision loss, but the vision improved after retrobulbar injection of Hyalase. Vivian Yin's group showed quite elegantly that optic nerve, fresh optic nerve occluded with HA filler, you couldn't dissolve it even if you left it in a bath of Hyalase for over 24 hours. So Hyalase doesn't penetrate the optic nerve. So that's a counter-argument against the use of retrobulbar injections of Hyalase. Kathy Huang and Bob Goldberg did some elegant studies looking at ERG and angiography in rabbits. And what they showed is that actually only one partially occluded central retinal artery of a rabbit had reperfusion, but no improvement in ERG, so another argument against retrobulbar Hyalase. This is another patient from the US who lost vision, had external ophthalmoplegia and central retinal artery occlusion. They received Hyalase, but the vision didn't improve. This is a recent case that hasn't yet been published. Now, interestingly, this is the first case that's now been reported with objective record of improvement of vision with retrobulbar Hyalase. And the Hyalase was given at day 4, so it took time for the patient to get from Korea to see an ophthalmologist who could treat with retrobulbar injections of Hyalase. And their external ophthalmoplegia, the ptosis improved. By 21, the vision had virtually recovered. This is the fundus finding. There's papillopathy and optic nerve swelling at day 5 when they received their injection of retrobulbar Hyalase. And by 3 months, they had full recovery of the vision and skin returned to normal. So really, I think we have to be careful when we say that we don't do retrobulbar injections of Hyalase. I think as a group, we are able to do these treatments, and I think we have to assume that we could potentially improve the vision. The 90-minute rule may not apply. within 15 minutes, if the central retinal artery is occluded, you could lose all vision. And there are lots of other methods of trying to improve the vision. So retrobulbar hyalase is not the only useful treatment. Reducing the pressure with paracentesis, ocular massage, and topical treatment is also helpful. So going back to my first slide, we have to remember that we have a niche place. We look after the eye. We can manage the complications as well. And we have to learn about how to do that. So I'd like to thank Richard Allen for inviting me and my co-authors. Thank you very much. Thank you.
Thank you.